don't you welcome everyone and tell us what you're doing today?
Hello, everyone. Welcome for another Friday episode with Reza and Ravi. We are really excited to have you all here. I will be doing teaching points. And yeah, if anyone has a case and want to present for us, please let us know. So yeah, how is Reza? I'm waiting for him to speak in French with us today.
Oh, my brain wants to answer you in French, but I just don't have the skill set. So I have to continue speaking English. Touche. That where I see Robbie smiling, giggling. He gets happy when I'm struggling.
Y'all, you should, I don't know. I think the subscription to RLR CP solvers may or may not be worth it medically. That's for you to decide. But to see Aaron and Reza speak in French back and forth to each other, oh my gosh, it's a treat. It's a real treat.
Les enfants devant le
Oh my god. Oh my god. You're a stand-up comedian who likes to sit down a lot, basically. Is my summary.
Oh my gosh, RLR in French. Then we'd have an excuse for getting all the answers wrong.
Prof. Rez, we planned on doing this for decades, so I think we should just cycle to a new language every like 10 years or so, okay? It's French for now, but we should move on. I want to do German. RLR in German.
Oh my gosh, what's that word in German where it's like you get joy from other people's struggle? Does anyone know what that word is?
Schadenfreude.
Yeah, say it again.
Schadenfreude.
Robbie has a lot of Schadenfreude.
Don't ask me how to spell it though.
Robbie has a lot of Schadenfreude for me.
All of it, the whole world of it, right here. Prof. Rez, can you believe it? In our foolishness and jokiness, we actually have a case presenter today. I don't know if you saw, it's our beloved friend who is decked out in a white coat today, probably at work. Hi, Jasdeep.
Hey everyone, I'm wearing the white coat because I'm actually on service as the attending for one of the resident team in the hospital, so have to look a little official.
One last joke. The last time Jasdeep presented a case, I ended up with the diagnosis of a DAT mutation. Now the final answer was just functional neurologic disorder. Jazz, we're ready for you, man. And then Maddie, maybe you can just say a few words too, because I know you'll be scribing, so we get everyone's voices out there on the world. And then after that, Jazz can present to Robbie.
Yeah, hey everyone. I'm super excited for a Jazz case, and we'll see what's in store. He presented another case, I think, to Robbie and I of contrast-induced encephalopathy. So we definitely have a treat in store today, I'm sure.
You guys are setting up the bar way too high. So hope this is a good case. Thank you again for letting me present it. All right, so first aliquot. This is a 36-year-old female, and please let me know if I'm speaking too fast for the scribe. 36-year-old female that comes in for a 1-week history of fevers up to 102 degrees Fahrenheit, and these are real fevers. She checked them orally. Myalgias, cough, sore throat, and malaise. She reports recurrent generalized body aches and fatigue since her COVID-19 infection 3 months ago. And she also reports mild ankle edema, but that's worsened throughout the day, nothing else contributory. She lives with 4 children who are asymptomatic. She is sexually active with 1 male partner and denies any past or recent history of sexually transmitted diseases. A couple of days prior to the symptom onset, she did swim in an indoor pool and a hot tub at a local hotel. I will give you guys the examination, and I'll stop after that, and some basic blood work, and I'll stop at that after for the first aliquot. So the examination was remarkable for tachycardia at 112 beats per minute. When we saw her in the ED, she was febrile at 101 degrees Fahrenheit. Blood pressure was normal, 119 over 78. Respiratory rate was 21. She was she had some hypoxemia of 98% on 2 liters of nasal cannula of oxygen. Basic lab showed negative COVID, a sodium of 127, which is low, a bicarb of 16, which is low, an anion gap of 17, which is mildly elevated, a BUN of 55, a serum creatinine of 3.80 with a baseline of 1, a GFR of 15. Procalcitonin was significantly elevated at 4.79, and liver profile was normal. CBC showed a white count of 16,100. Hemoglobin was low at 8.6. Hematocrit was low at 27%. LDH was elevated at 235. And iron studies, haptoglobin was normal. Iron studies was low at 9. Low transferrin at 93, low TIBC at 126, and elevated ferritin at 528. Reticulocyte index was also low at 0.23. And then I also have the initial chest X-ray if you guys want me to share that as well.
Yeah, go for it. I can make you co-host if you have the picture. Otherwise, you can just say the report, whatever you're planning, my friend.
Yeah, I can say the report as well, but let me just pull up the image here. Okay, sorry about the delay. So that's what the, can everyone see that? Okay, so it was basically notable for a upper lobe consolidation on the right side. And that's the end of the first aliquot.
Oh my gosh, I feel like we just sat on a bullet train, Justine. That was incredible. I think I'm very intrigued by this case, but also equally intrigued by knowing, by wondering why you've given us so much upfront. And that makes me really, really worried about the patient, knowing that we have 45 minutes left to go to discuss this. So I think if you're practicing on how to present a case, you'll see how with more and more expertise and more practice, you start to know how to tell a story differently. And here you're seeing Justine give us so much information up front, probably anticipating that this will be a complicated course. Prophet, I'll just share honestly one sort of big guiding principle with regards to inflammation and infection. I would love to hear how you're zooming into the details for this patient. I think we've said this many times, it bears saying just to be precise, which is acute inflammation is infection until proven otherwise. So the first question to answer is how confident are we that this is acute? And I would say that in general, you should be pretty confident. However, when the story gets so complicated and tricky, which we subsequently learned about, and then when we heard that the patient has had body aches and fatigue since COVID 3 months ago, my mind isn't completely locked into the idea this is acute and worried that this may be acute on top of some subacute syndrome. But I think in order to manage the cognitive load and proceed with some hypotheses, I'll make the assumption that it's acute, recognizing that it is not known, but rather an assumption. So acute, again, inflammation is a fever until proven otherwise, but here the acute is in question mark. And as a general principle, there are two kinds of infections, really. Infections that are from commensal bacteria. These are organisms that live on your body and then cause an infection by compromising your immune system in some way, shape, or form. They're very common. Staph cellulitis, Klebsiella pneumoniae, E. coli cholangitis, so on and so forth. These are bugs that live on your body, and if you culture them from non-sterile sites, you'll find them, commensal organisms. The other category is actually organisms that should not be found on your body. These are called environmental or non-commensal organisms. Why is this branch point helpful? It's helpful because in patients who are having infections with commensal organisms, they usually have a dominant localizing syndrome, meaning they come in and they complain of one specific area that is inflamed. Their leg is inflamed, their urine is inflamed, their liver is inflamed, their gallbladder is inflamed, their bowels are inflamed, or their lungs are inflamed. However, patients with environmental infections, such as viral infections, atypical bacterial infections, fungal infections, and parasitic infections, these organisms, the body's not ready for them. And so when they come into your body, they usually disseminate. That's why almost every patient with a viral infection has myalgias, fatigue, because the virus is everywhere. It's in the respiratory tract, but it's everywhere. That's why patients with tick-borne infections have headaches and nausea, because the infection is everywhere, so on and so forth. That's a general rule of thumb and not definitive, because infections by commensal organisms like staph are often localized, but they can disseminate. You can get Staph aureus bacteremia and they go everywhere. So here, the first 3 lines suggest either an environmental organism or the rare situation where a commensal organism has disseminated. And that, I think, is an operating framework to begin to analyze this case. And it'll certainly, we'll certainly have to balance each of these competing hypotheses, an environmental organism or a commensal organism gone deeper than it usually does. Pafraz, what do you think?
I love that approach, Robbie. And I do want to say that we have a lot of data here, and it's easy to be overwhelmed, but there's no need to be. And we want to be as honest as possible to this exercise. So I'm literally putting myself in the position of Jazz and the clinicians who are admitting this patient. And the simple frame comes down to acute inflammation with a pulmonary focus plus minus renal focus. And I'll say why I say plus minus renal focus, but I'm very confident of a pulmonary focus. The pulmonary focus is evident on physical exam, where this young patient, presumably with normal lungs, is requiring 2 liters of oxygen to have an O2 sat of 98%. And then we obtained a chest X-ray, which further confirmed pathology within the lung. Now, when you have pathology within the lung, that could represent white blood cells in the form of pneumonia, fluid in the form of edema, and red blood cells in the form of hemorrhage. From the start of this journey, Robbie, I think we capitalized the I and I made because infection is prioritized. And what infections cause an acute presentation? Those include bacterial organisms, the ones that we're familiar with, like S. pneumo, H. flu, mycoplasma, and atypical organisms, stuff like Legionella, chlamydia, the various causes of community-acquired pneumonia. But it also includes viruses. In fact, if you ask the question, out of 100 patients with community-acquired pneumonia, how often do we actually get an answer, a pathologic answer, right? We send sputum cultures, we send urine Legionella, urine strep, etc. Only 40% of the time. 60% of the time, we do not identify a pathogen. So when you're thinking of pneumonia, bacteria, community-acquired pneumonia, and viral, we have a very good illness script on CAP. Maybe someone can put it in the chat that's on our website. But then you come down to the laboratory data. And here, you're seeing that there is hyponatremia. Your inclination will be like, okay, let me approach hyponatremia, but you should stop right there. Before you get too excited about the hyponatremia, look at the creatinine. So this is not a story of hyponatremia. This is a story of acute kidney injury. And the reason I had plus minus kidney, because the kidney is such a sensitive organ to perturbation. I barely can even speak English, to derangements, where it's quite vulnerable. So the kidney is often a bystander in the scheme of a patient's presentation. But here you got to be cautious with that, because one, the creatinine is quite high. I'm neglecting the hyponatremia, and I'm asking what's causing the AKI. So we have lung over here, we have kidney over here, and the kidney, it's pre-renal, renal, or post-renal. Post-renal in a woman is far less common than a man, but it can happen depending on the medications they're on, but I don't think it's post-renal. There's definitely a component of pre-renal here of hypovolemia, because the patient has been sick, has had myalgias, is probably not feeling well. So there is a component of hypovolemia, but I would be shocked if there wasn't a component of intrarenal AKI. And once you say intrarenal AKI, just come down on the journey with me, the glomerulus, the tubule, the interstitium. And ATN is probably the most common cause of intrarenal AKI in the hospital setting. And she's very at high risk of ATN. And for ATN, you don't need hypotension. Just inflammation alone can cause acute tubular necrosis. But I think this is where it gets a bit exciting. What I mean by that is, what if we link the lungs to the kidneys? Probably the most common way to do that is someone just has a pneumonia, has sepsis, has ATN, and has AKI. That's probably the most common way to do it. But when you say young, you say woman, you start thinking, could she be at risk of an autoimmune disease that has a pulmonary renal signature, like your ANCA-associated vasculitides? And many of those, like GPA, MPA, can have upper respiratory symptoms in addition to the consolidation that's in the lung. That would be less likely for me than just pneumonia and AKI. That's why I put the plus minus kidney, but it's really those ANCA-associated vasculitides and some other conditions like lupus that can have a footprint in the lungs and the kidneys. So if I were to step back from all of this stuff, she definitely has some iron deficiency anemia. It's not uncommon in a premenopausal woman, but there's also anemia of inflammation as evident by the very high ferritin level. And I bet you if she was iron replenished, the ferritin would even be higher. The retic index being low is not surprising at all in the context of inflammation. So Robbie, maybe because we got so much data here, I'll just pass it back to you. I'm just trying to be as realistic as possible. I'm in the ED. The myalgias maybe prioritize viruses or certain bacteria like Legionella, Leptospira, and some other stuff. But honestly, I'm just treating this as a pneumonia with ATN, but I want to look at that UA. I want to see, is there proteinuria? Is there red blood cells to see if it's pulmonary renal?
100% Prof. I'm right there with you. I have nothing to add to that. And what I'm really most curious about next steps, what I would want to know immediately, which is not realistic, is what the blood cultures are. Because if the blood cultures are negative, then I think the idea that this is a disseminated commensal organism essentially plummets. And I think we're very much solving what kind of exogenous organism caused this. And to do that, we'll study the signature that's happening to the patient and also the risk factors. So exposure to kids, sexual activity, and then exposure to indoor water sources will probably be important clues. But yeah, really, really intrigued to see it. I'm right there with you. All right, Jess, tell us more.
My French is not as good as Reza's, but I think that was magnificent. And from both of you. But I before this end of this VMR, Reza and Robbie, if you guys can say "oof" again, that'll make my day. I believe that's how you say egg in French. The next aliquot is going to be a little bit smaller. So she was started on ceftriaxone and doxycycline for coverage of community-acquired pneumonia. We did get a CT scan, which basically corresponded with the chest X-ray, multifocal pulmonary opacities with dense area in the right upper lobe consolidation. Hemocult was negative, vitamin B12 and folate were normal. A UA did show 3+ protein and a 3+ blood. The microscopy showed 3 to 10 red blood cells per high power field, which about 50% of them were dysmorphic. 11 to 20 white blood cells per high power field, and then about 11 to 20 granular casts were also observed. And then a urine total protein to creatinine ratio was sent, and it was 1.7 gram per gram for creatinine. Blood cultures, Robbie, were sent and they were negative. Urine streptococcal antigen was negative, and a urine Legionella serogroup 1 antigen returned back positive. At this point, ceftriaxone was discontinued and the doxycycline was changed to azithromycin. That is the end of this aliquot.
Wow, this is super exciting. And hopefully the patient has a good outcome. Robbie, what I'd like to do is just comment a little bit on the Legionella. And distinguishing glomerulopathy from glomerulonephritis, and then maybe I can hand you the mic to actually get granular with the various causes of glomerulonephritis. Right away, when you want to assess whether someone has glomerular pathology, the most sensitive test for that is assessing whether there's albumin in the urine or not. Why? Because albumin is this large, high molecular weight protein that should not filter through a normal, intact, healthy glomerulus. So when you get albumin in the urine, and how do we check for albumin? Actually, the dipstick is only checking albumin. So if the dipstick is positive, you diagnose pathology of the glomerulus. We call this glomerulopathy. But the glomerulopathy, you have to determine if there is an itis to it. Is it inflamed or not? Can you think of examples of just glomerulopathy? What are common examples? Put it in the chat. While you're putting that in the chat, I'm going to comment on the inflammation component. So when should we think about inflammation? Of course, if there's systemic inflammation, you have to be worried. Could you have an inflammatory glomerulopathy, which equals glomerulonephritis? But other reasons to think about it. If you have red blood cells in the urine, red blood cells in the urine can be caused by a whole host of factors like kidney stones, etc. But if you have proteinuria, you don't have a history of diabetes, you don't have a history of hypertension, and you have red blood cells, you now have to really be concerned for glomerulonephritis. And remember, you can have focal GN where you have no systemic signature, so the lack of inflammation doesn't extinguish that possibility. But how can you become even more confident? These dysmorphic reds, imagine a red blood cell, right? It hits the glomerulus. It shouldn't filter if the glomerulus is okay. But what if the glomerulus is damaged because of inflammation? Now, when the red blood cell goes through that glomerulus, you get the Mickey Mouse ears, you get the dysmorphic reds. But the problem with that, my friends, is that I would say that 60% of nephrologists can't even identify dysmorphic reds because it's just not that sensitive. So if it's there, it's specific and you've diagnosed GN, but its absence, again, doesn't dissuade you from this diagnosis. And I think this is the beauty of medicine, like the subtleties. The subtleties are the beauty. But red blood cell cast, they're probably easier to identify on urine microscopy. And this is basically when you have red cells enter the nephron, and you have secretion of the Tam-Horsfall protein, then the red blood cells get into the Tam-Horsfall protein. Now you have red blood cell cast. So basically what Jazz has told us with the proteinuria is that there's glomerulopathy. With the hematuria, the dysmorphic red cells and the RBC cast, that there's glomerulonephritis, that there's glomerulonephritis. With that being said, I'd love to pass the mic to Robbie to take us further from there.
Thank you for that spectacular teaching and making such a compelling case for an unexpected finding, glomerulonephritis. Because I think if you're wondering, Legionella can definitely cause kidney issues, and the mechanism by which it does that is acute interstitial nephritis. So it's affecting the adjacent compartment. So one thing to reflect on is to say, is this case done? Because there's Legionella and it causes kidney issues, and the answer is no, it's not. And the reason it's not is because Reza just made a compelling case for the kidney involvement not being what we associate Legionella with, which is acute interstitial nephritis. So the earnest reflection would be like, wait, hold on. Just because it causes acute interstitial nephritis most classically doesn't mean it might not cause glomerulonephritis. So I might actually just see how often Legionella does GN before speculating on whether the patient needs more of a workup. But my initial reflex is to say yes, that this patient needs more than that. So if we start with the glomerulonephritis as a whole, it's helpful to classify glomerulonephritis by complement level, with normal complementemic glomerulonephritis being usually due to ANCA-associated disease, but also two other considerations, IgA nephropathy and anti-GBM disease. Hypocomplementemic glomerulonephritis can be as a result not just of the three autoimmune diseases that we just talked about. So normal complementemic is autoimmune, ANCA, IgA, anti-GBM. Hypocomplementemic, the DDX is much wider, includes infections like post-strep GN endocarditis, includes cancers like cryoglobulonemic cancer from lymphoma, and then of course autoimmune diseases, the most famous of which is lupus. An important one to also add is C3 deposition disease. And the reason I bring that up is, in addition to considering the base rate of glomerulonephritis, again, by complement levels, we should also wonder what kinds of glomerulonephritides occur in young people. And a clue there is ANCA disease is usually a disease of older adults. Lupus is a disease of young people. The other variable here is what kind of glomerulonephritis not only occurs in young people, but also occurs as a syn-infectious or para-infectious process. The champion example of an infection triggering glomerulonephritis in a paraneoplastic manner is post-strep GN. There's no strep actually there, it's paraneoplastic or para-infection. And the two most common glomerulonephritis that are triggered as a consequence of a distant infection are IgA nephropathy and C3 deposition disease. One of which is normal complementemic IgA, the other C3 deposition disease is hypocomplementemic. So I think we need to look at GN from a fresh perspective, independent of the other details in this case, because base rate is base rate. And the complement levels will help us filter them into two categories: normal complement, ANCA, IgA, and anti-GBM. Of that list, all three, ANCA, IgA, and anti-GBM, can be triggered by infections. But the one most classically associated and has the strongest link in that list is IgA. And the curiosity is it tends to affect young to middle-aged people, which this person is. Within the normal complementemic category, again, we have to, within the hypocomplementemic, we have to think of infections. Endocarditis is made less likely by the normal blood cultures. We'll have to think about cancers and sending off an RF and a C3, C4 for cryo. And then autoimmune diseases, an ANA. And again, the C3 level will be very, very helpful for C3 deposition disease, which of all these things is also, like IgA nephropathy, classically linked to an infection. All right, Jess, the mic is yours.
One thing I was thinking, Robbie, is
Yeah,
that,
oh, please, sorry about that. Yeah.
no problem. If this patient didn't have the pulmonary findings, this case would be actually more straightforward, meaning I would be rushing to a renal biopsy, right? But the pulmonary findings is what makes this more difficult because of the infection and then post-infection complications that may occur. For example, the IgA nephropathy, where you just are supporting the patient. So I think this pulmonary opacification actually keeps this DDX very broad. And I'm very curious to hear how Jazz and the team tackled it based on the broad scope, as opposed to if it was just kidney, you just go right after the kidney.
That was great. It's always so much fun listening to you guys both reason out each aliquot. This is like a real treat. My next aliquot may be another short one, so if you guys want me to give you the one after that, just let me know. So the next one, basically, further laboratory testing did reveal a positive ANA in a speckled pattern with a titer of 2,560, a positive double-stranded DNA antibody at 346, a positive anti-Rho, SSA, SSB were both positive greater than 8, with the upper limit of normal is 0.9. Anti-RNP, anti-Smith, ANCA screen, and anti-glomerular basement membrane antibody were all negative. C3 were low, that's 49, with the lower limit of normal is 90. C4 was low at 5, with the lower limit of normal is 10. I'm actually going to go ahead and give you guys the next stuff, actually. The patient, so the part that didn't really was confusing was that the patient's kidney function and symptoms rapidly improved with administration of IV fluids and antibiotics, which is kind of atypical when it comes to like true GN. Just usually patients who are have glomerulonephritis, it takes some time, but like within like a day, her kidney function improved. And like socially, because she was a single mom with 4 kids at home, she was kind of like, hey doc, I'm feeling better. Can I be discharged? I'll follow up with nephrology and other people in the outpatient setting. So we actually discharged her from the hospital with plans with outpatient kidney biopsy. And at discharge, her serum creatinine was basically back at her baseline, which is 1.1. And she returned, unfortunately, though, to the hospital 4 days later with worsening dyspnea, cough, lower extremity edema. Examination was notable for an elevated JVP, bibasilar rales, bilateral lower extremity edema, now 2+ up to her kneecaps, or like right below her kneecaps. An examination was, and then COVID PCR now is positive. Chest X-ray revealed interval improvement of the right upper lobe consolidation, but now there's bilateral interstitial and airspace opacities, which I will, and it was basically, hold on, where'd it go? Yeah, and then basically her pro-BNP was elevated 61,000. A echocardiogram did show a eccentric left ventricular hypertrophy with mildly reduced left ventricular ejection fraction at 41%. There was also a small circumferential pericardial effusion without tamponade physiology. Troponins were mildly elevated, but they were static, and an ABG revealed a pH of 7.17. Oxygen of 78%, PO2 of 78 millimeters of mercury, and a bicarb of 16. And this time around, her serum creatinine was 1.8. I'll stop there.
Ooh, there's a lot to digest here. And yeah, maybe Prof. Rez, I feel like you were setting up the glomerulonephritis conversation. So I'll leave that dimension to you and just reflect on the new cardiac dimension, which has emerged here. And I think that the, glomerulonephritis is definitely best analyzed by concomitant pulmonary involvement, as Prof. Rez just said. But I think that whenever you get serosal involvement, namely the pericardial dimensions here, I think that can also be a very powerful filter. So I think the question really is, does this patient have a connective tissue disease as evidenced by her serology? And I think the presence of a pericardial effusion offers a significant impetus to the idea that it is that those rheumatological serologies have a clinical correlate. But there are many, many possibilities for this pericardial effusion, including it being related somehow to her kidney dysfunction, although her kidney dysfunction is not in proportion to how impressive this pericardial effusion is. They're also not just, there's obvious pericardial effusion, but the static and persistent troponins suggest a myocardial involvement. And of all these things, of course, lupus explains all three of them. But whenever you have COVID and myocardial involvement at the same time, you have to wonder whether it is COVID-related, specifically MISA or multi-inflammatory system A. So I think the real question for my mind is, independent of the kidney stuff, which I'll leave to Prof. Rez, is this patient have a subclinical autoimmune disease, probably best described as lupus, that is being brought about by unfortunate but recurrent infections, Legionella first and COVID now. Will treatment of these infections result in quiescence of the disease, or will the disease emerge independently of those conditions? But I think the cardiac involvement is best characterized as myopericarditis with resultant heart failure, which is very much in line with an autoimmune disease, but may be explained by MISA from COVID.
Robbie, I think that's terrific. And truthfully, with the ANA titer being that high, and then the double-stranded DNA being positive, like I am almost with the glomerular involvement, it's hard for me to say that this is not lupus, like this to me is lupus. And if you ask the question, of course, there's a slick criteria where you can go through and look, and I know it's confounded by her acute infections, or you can do a kidney biopsy, which can show lupus nephritis. But I just like, the titer, like ANA is a good screening test, but that titer is just so high. Meaning, I don't think people have examined the specificity of ANA based on the specific titer of 1 to 2,560. Then you couple that with the double-stranded DNA and this clinical picture. And then you may ask the question, how do patients with autoimmune disease present? Well, they present with flares of their autoimmune disease. They present with opportunistic or infections, increased frequency because the immune system is not acting properly, or they present with clot, thromboses, especially patients with lupus. And so this ends up being sort of a nightmare to manage, because I'll tell you, on that first hospitalization, honestly, I don't even care what the creatinine is. Like, you can have a raging GN with a normal creatinine. I learned that, from my friend Manny. And so the degree of proteinuria in that first hospitalization with the clear GN and the positive ANA and double-stranded DNA, I would have actually suggested we give high-dose steroids. Maybe you treat the Legionella because the patient's at risk. Maybe you give 3 days of antibiotics, but then you do 1 gram of methylprednisolone. Now it's easy for me as an internist to make a comment like that. It's much more difficult when you take in the social situation of the patient, them wanting to go home. But I know some nephrologists that would have really advised for high-dose steroids. And I think where I am right now is, like, we have COVID-19, and we know with severe COVID, we give steroids, but it's not, high dose steroids of 1 gram. But I think this patient needs it. I think you're getting multi-organ failure from the underlying rheumatologic disease, and that's also making her vulnerable to all sorts of infections. Now, this is beyond my scope, and this is where I would talk to the rheumatologist and weigh the risk benefits, but I think we just need to give, I think we need to give some high dose steroids. Yeah, you know what? Don't change my handle. Keep it at RX, because today we're talking treatment, baby.
Great. I just want to shout out Deborah with just keeping up with the teaching points. Yesterday, Maddie did such a fantastic job, and I think Hans called it a box of pearls or something like that. It was excellent. So just keeping up with the teaching points is pretty impressive to see that. All right, so next aliquot. The patient unfortunately developed rapidly progressive hypoxia requiring intubation and mechanical ventilation. When they intubated, they noted frothy, bloody secretions, and there was an acute worsening of her anemia from a hemoglobin of 7.2 to 6.0. And this was the following chest X-ray. Let me share my screen. And while I'm pulling up the chest X-ray, cardiology was concerned about lupus myocarditis from the echo. This was the X-ray now.
And Jazz, maybe I can just quickly say that when you see bloody secretions, most often it's because there's some trauma in the form of the intubation. It doesn't diagnose DAH, but Anne-Marie is spot on here. In this context, it is DAH until proven otherwise.
All right, so let me go back to, and then furthermore, sorry, 1 second. Over the next 72 hours, her kidney function continued to decline and she became anuric. The patient's respiratory failure did not improve with 2 days of broad spectrum antibiotics. And then she was started on intravenous methylprednisolone for concerns for diffuse alveolar hemorrhage with improvements in her hypoxemia. She was then placed on continuous renal replacement therapy because of her anuric renal failure. And then a kidney biopsy was performed. And I'll stop there. The next set of information is going to reveal the diagnosis.
And I'm going to pass the mic to Robbie, but I just have a question for you, Jazz. Can you just tell us the discussion that took place? Because everything was yelling lupus, and that, like, the organs were like, the discussion of like giving high dose steroids versus not, and like when was the actual trigger pulled to do, like, how was that with the consultants?
Yeah, that's a great question, Reza. So I was involved in her care the first time around, and then the second time around was more just like, because learning from Gurpreet Dhaliwal is like chart reviewing and making sure an interesting patient. So I was just keeping tabs on her. So the first time around, I was actually concerned about lupus, but the nephrologists that were consulted at the time they're like, yes, it is possible, and we're going to definitely work this up outpatient. But they felt that the response to IV fluids was a little bit atypical. So at the time, they were thinking maybe Legionella GN, which there's no cases for, at least that they were able to find. So they were like, it could, maybe it can't. They've seen like very minimal cases of Legionella-induced GN. So that's why she was discharged. When she came back, like you mentioned, Reza, and like multiple things can cause bloody secretions, and they do different types of like lavages in this, they do suction, and basically her bloody secretions were only there for the first 2 lavages, and the other ones there were not bloody secretions. So they were like maybe diffuse of it, or maybe this could just be worsening hypoxia from her, maybe from the Legionella, because she was almost about finished her antibiotics for that. So they were still on the fence about it. So, but because her lung function did not improve, they decided to do steroids, and then that did eventually bring her back to her baseline. But and I'll talk about this at the end, but nephrology was like, this definitely could be lupus, but then they also mentioned a couple of things that Robbie mentioned too. So that's why they wanted to get the kidney biopsy to be really sure of the diagnosis.
And Robbie, let me ask you then. Thank you so much, Jazz, for that explanation. Makes sense. What is giving you pause to say that this is lupus? Like with those titers, maybe I'm being a little ignorant here.
Oh, not at all. I think that it's so hard to be like it's so hard to just analyze the data alone in this case, because you're not there seeing the patient, and also like it's hard not to be influenced by other people's opinions. But I'm going to really try to just be like, if you just look at the stuff in red, and if you highlight the patient's age, 36-year-old woman, proteinuria, hematuria, dysmorphic red blood cells, positive NA, positive double-stranded DNA, that should get you to 99% lupus. I think that we should establish that. But then you might ask yourself, okay, well, why is it then so important to get to 100% lupus? It's a deadly disease. And I learned this from my rheumatologist. The reason they like to get to 100% is because the implications for persons don't have lupus for a day or two. They have Legionella for a day or two a week. People have lupus for a lifetime. So the importance of diagnostic clarity may not be so important in the moment. You give prednisone, the patient gets better. It's important to be like, well, how do I treat the patient for the rest of their life? And so that, I think, pushes a lot of our experts to be like, okay, well, what's the counter argument? Because usually when I'm on the medicine side, I'm like, come on, like this is so obvious. But I hear that their hesitance usually comes from the fact that they're going to be taking care of the patient forever when we're done from the admission, you know? What are the unusual things? The unusual things for me are that this disease seems to be flaring in the context of an infection. Is that characteristic of lupus? No, it's not characteristic of lupus. It's characteristic of some other glomerulonephritis like IgA and C3 deposition disease. It's also, I think, a little bit unusual to me that the patient doesn't have leukopenia and thrombocytopenia, but they may have developed. It is very concerning that the patient has had pericardial effusion and diffuse alveolar hemorrhage. So honestly, if I were to give this honest prediction, I would say this is like 95% lupus. The part that's giving me pause is wondering, well, why is the patient keep flaring with infection? That's not, I can see that being a lupus thing, but it's not something I know. So then I would bring in the idea that C3 deposition disease in particular is associated with autoimmune diseases, and that this might be a lupus-like disease, not overt lupus, that is just like a positive SPEP doesn't mean myeloma. It could mean like a myeloma-like disease, like Castleman's or whatnot. Could this be an immunologic phenotype of incomplete lupus C3 deposition disease? Or could this be Sjogren's syndrome with cryoglobulinemia, with the really, really low C4 being suggestive of that? But gosh, I mean, I think that 5%, those thoughts are only 5%. And the only reason I think people would pursue them is that these diagnoses, whatever you give to the patient, aren't transient, they're lifelong diagnoses. But those are my reflexes. I'm curious where your head is at, Prosraz. What is your like scale of probability?
No, I love that. And I think the way I'm like compartmentalizing this in my mind, as far as like management reasoning, is what do I need
Yeah.
to do acutely to preserve kidney function
Yeah.
and prevent irreversible damage? So I totally appreciate, and I love that, like long-term, you do want 100% diagnostics, although you'll never get to almost with anything, but short-term, like for example, if you have a septic joint, if you have a post-obstructive uropathy, like you have to act quickly. And I know with GN, now I don't know all
Yeah.
the studies and all the data, but like in the middle of the night, the nephrologist will be like, give them 1 gram methylpred. It won't affect the biopsy results, just to save those nephrons. So I'm just trying to compartmentalize this into acute management. Like, what do you do in the moment? But I've seen nephrologists also send people home with GNs, with proteinuria, but I know nephrologists that take it very seriously and think about, so then you give it acutely, like immune activation NOS, long-term, we'll figure out the rest later.
Yeah. Really good point. All right, Jazz.
Awesome. All right. I just wanted to
Now I
highlight.
didn't commit to a diagnosis there. I sneaked in a different teaching point.
No, that was great, Reza. So I guess one of the reasons I wanted to present this case was obviously good differential, but also management. So I'm glad that you guys did that. Because initially, when I first saw this patient, I was like, this has to be lupus. And then nephrologist had to be like, Jazz, let's take a few steps back. Let's look at other things too. So, all right. The biopsy. And that's Robbie, to your point, they're also like, could this be C3 deposition versus lupus, and specifically what type of lupus? And that was the teaching point for me too, and which is what I'll share now. So biopsy showed diffuse increased mesangial matrix and increased cellularity. The glomerular basement membrane showed wire loop deposits. There was hyaline thrombi with 3 fibrocellular crescents and endocapillary proliferation of glomerular tufts. I have no idea what I'm saying. There are minimal fibrosis. Immunofluorescence showed +1 IgA, +1 to 2 IgG, 1 to 2 IgM immunoglobulins, 2+ kappa, 2+ lambda, 2+ C1q, and then also C3 in the capillary loops and the mesangium. IgG was the subtype that was predominantly elevated, that was found, and it was specifically IgG3. The electron microscopy revealed numerous subendothelial deposits, and there was about less than 20% podocyte foot processes effacement. So basically, long story short, they basically said that this was type 4 lupus nephritis, and they decided to start her on cyclophosphamide in addition to the methylprednisolone, and then sent her home with outpatient prednisone. They also started her on PJP prophylaxis due to the prednisone, and she went from CRRT to intermittent hemodialysis, and her now 6 months out, 6 months after her discharge, she's back to her baseline creatinine. She basically barely has any proteinuria left and has responded very well to treatment. So I guess the thing for me was, even when the things look exactly like lupus, to have C3 deposition disease, and then also to really further classify. I mean, this is not really in our realm, but it's good to know that there's different types of lupus nephritis and the biopsy, because like it does change long-term management of how they're going to treat that.
Jazz, I thought your conclusion was going to be the nephrologists have no idea what they're talking about. I knew it was lupus all along, but you're too humble. And Robbie, let me hit you with one of these, my friend.
Wait, what are you hitting me with? What did I just get? Oh, I didn't see. Prof. Rez, I should just explain to everybody that is Marcus Rashford's goal celebration, and it is now Prof. Rez's diagnostic celebration. So congratulations. I'm really humbled by this case. I think that I can't wait to dive into it more and read more about it, understand about the infection and how they continue to be a part of the story. I think it's true that lupus is not a single disease. I think the fact that it can show up so differently in so many different people. Some people show up with a rash and lymphadenopathy. Some people show up with devastating renal involvement. I bet you it's multiple different diseases. And if I were just to continue that speculation, I bet that you're seeing a unique subtype that seems to really be responsive to getting infected. And I'm curious if that's been described more, if that's a subtype that we know about. And I'm really excited to learn more about that. But an amazing case. Thank you, Jas. It was really, really educational and took us beyond the whole marathon. And I'll pass the mic to you, Prof. As unfortunately, I have to, well, not unfortunately, fortunately, I get to hang out with my lovely team and fun with them. So I will bounce and have a wonderful day, y'all.
Well, mon ami, Deborah, it is your turn, my friend. Bye, Robbie.
Bye, Robbie. Thank you, Jess. It was such a great case. Thank you, Robbie and Reza. So I will try to go for the most important teaching points. So yeah, in the beginning of the case, Robbie said that with this acute inflammation, it was infection until we prove otherwise. And we have two kinds of infection. That could be from commensal bacteria that lives in your body. That could be very common. Or could be organisms that should not be in your body, and your body can be inflamed, and that could spread to your whole body. And then Reza presented that this case, we had the patient with acute inflammation, a pulmonary focus, and maybe a renal or sinus focus. And the pulmonary, we could saw by the requiring oxygen and then the chest X-ray that presented a pathology in the lung. And going for the hyponatremia, Reza said that before we're talking about hyponatremia, we should see the creatinine, and that could represent that was an acute kidney injury. And we went for the causes. That could be post-renal, but he said that can be less common in women, or could be pre-renal from a hypovolemia, or intra-renal from ATN. And then we went for the journey for the glomerulopathology, and if could be inflamed or not. And here it could be inflamed with the systemic inflammation, or we could see like red blood cells in the urine or proteinuria. And probably teach us about the complement, that in a glomerulonephritis, we can see a normal complement or a low complement. And normal, we could think about ANCA, EGM, a fibrillar GM, and the low, we can think about infection, cancer, or maybe a lupus. And the lupus can manifest with recurrent infection because of the immune system of the person, or could manifest with thrombosis. And here with the N of 2,560, we have a high sensitivity. And in this case, Reza told us that we could first treat the Legionella and give corticoids. And yeah, and then in the end, that teaches that how the lupus can presenting different types, and then how that changed the treatment. And yeah, that lupus is not a single disease, and some persons can present with rash, adenopathy, and infections. So yeah, that's the teaching point for today. Thank you, everyone, and thank you for this case.
Thank you so much, Deborah. I was gonna say bon chance or bon courage, but you don't need it, my friend. Thank you so much. Au
Thank
revoir.
you.
À tout à l'heure. À bientôt.